very interesting session, that is emergency life-saving cases. And the chairpersons for this is Dr. M.S. Hermat and Dr. Manish Bansal and Dr. Ramesh Babu P. as the chairpersons. Please welcome, sir. Meenakshi. Yeah, please. And the moderators for this session is Dr. Hariyam Tyagi, Dr. P.L.N. Kapati, Dr. Gopal Krishna, Dr. D. Rajashekar, Dr. Syed Imamuddin, Dr. K. Meenakshi, Dr. Prasad Sa, and Dr. Gudapalli Ramesh. Please, sir. Now I hand over this session to chairpersons. Sir, please continue.
So good morning, we start. So we're equal, same number of people that side as well as this side. Anyway, we don't wait, and we have first presentation by Anantraman, successful PCI after tower.
Good morning, chairpersons, and I take this opportunity to thank the organizers to give me this opportunity to present this interesting case. Now, currently I'm working as a senior interventional cardiologist. Can we enlarge this, please? You can see it. Thank you. I'm interventional cardiologist at Frontier Lifeline in Chennai. Now, my training with TAVI and everything is in UK. I was there for 22 years in Liverpool, Cardiff, and Manchester. And this case I'm sharing today is one during my sort of fellowship with TAVI being sort of increasing in India now at the moment. It's important for interventional cardiologists to understand what sort of the different valve is, and also what is the technique we need to use to recross these valves if you come across one in terms of coronary intervention, because each one is unique. Now, this is a 64-year-old lady with hypertension, scleroderma, severe restrictive lung disease, rheumatoid, and previous stenting in 2008. And subsequently, she's diagnosed with severe aortic stenosis. And because of this scleroderma, she was considered high risk, so she had a transcatheter valve implanted. That was done under IVA's guidance, and it was fine. At that time, the distal left main stem was only mild disease. So she went on to have the transcatheter aortic valve with a core valve, 26 core valve, in October 2011. And she was admitted during my on-call day in 2013 with acute coronary syndrome, global ST changes with ST elevation in AVR. So she was taken to cath lab, and aortography was done. So that is mandatory. That's one of the things you need to remember. If somebody had a transcatheter aortic valve, comes with acute coronary or ST elevation, please do start with an aortography. So aortography was done. Following that, a selective angiogram is done. Now, so that image shows the aortography. The distal left main is critically stenosed, 99% stenosed with TIMI-1 flow in LAD and circ. And that clearly shows the stenosis. Now, this cannulation of this through this core valve is an important aspect, technical aspect of this presentation. Subsequently, now there are a lot of review literatures that has come. It's better to use a smaller Judkins JL3 and cross it at a level which is coaxial with the left main stem. Do not go under. That is very important. I'll show you later. So this case was done accordingly, and during the second injection, the patient went unstable, heart block, and we kept IABP TPW on standby. Quickly reclosed with the JL3 fibritose and 2 wires, both LAD and circ, pre-dilated both, and stented both in a culotte fashion. And I was confirmed very good stent position of LAD circ and left main. Now it is very important, the last point I put here, you have to disengage the guide over the wire. And if there is any difficulty, put your balloon catheter back and that will give you support, and disengage it over that. Make sure you have disengaged from the ostium of left main or ostium of right before you take it out of the cells of the core valve. Otherwise, there is a big chance of entrapment, especially if you have gone underneath the coronary and come up. So this shows the end result. So that was the wiring both, that was the kissing balloon, and that was the end result. So patient was stable. And so technically, once you have the sort of technical ability to cross this core valve, which is shaped like this, there is a concave border like this, so you have to cross through one of these cells, and you should not go underneath the sort of coronary ostium and come up. And the reason for that is, I'll show you in the next slide. Now these are the recommended catheters. If you're going radial, use a JL3 for the left, and if you're for the right, use an Amplatz right one. If you're going from femoral, use a JL 3.5. If you're having difficulty cannulating selectively, then take a non-selective shot, cross it with the wire, and then railroad your catheter over that wire. If you're still having difficulty, use a mother and child technique. Use a 7 French, through that you put a 5 French and railroad it. The reason being, if you don't do that, you will come across one of these, catheter entrapment. And the next video will demonstrate that. So when your catheter is caught like that, when you're trying to pull, the guide catheter will get caught in one of these cells. Either you will discharge the valve or you will dissect the left main. So it's very important to know this aspect of this core valve, and you have to go from the upper cell, which is coaxial with the left main, and when you are disengaging, make sure you are disengaging from the left main first, over the wire or over your balloon shaft, and then gradually pull it out. Otherwise, you'll have a lot of trouble. So the key aspects, obviously the indications are expanding, and you will see more and more of these TAVI valves. And also these patients are elderly, so you will see a lot of these patients having coronary disease. So you need to know the know-hows of these valves, how to cross it, and if you have difficulty, call one of the seniors who have got experience with these TAVI valves. And post-TAVR, if it's an elective case, do a CT scan. It will give you a lot of information. The CT scan will be a lot of information about the lie of the valve, about the origin of the coronaries, and all the aspects you need to know. But in the acute cases, it's difficult. So perform an iotography first. That is mandatory. To know the valve, to know the takeoff, everything. Cannulate the ostium through the cell, which is in line with the ostium of the coronary, and try to disengage in a fashion I mentioned, over the wire and over the sort of balloon catheter shaft. Never pull it from underneath. Now, one of the sort of core valve markers is, if you calculate the diamonds, the skirt which prevents paravalvular leak, it's about 2.5, and the commissures is about 5 cells. So you have to cannulate above that level. So please do remember that. So a good understanding of all the transistor valves. At the moment, what is available in India is Evolute core valves is available, Edwards is available, my valve is coming, and the Brazilian valve is available. So know about these valves and how they sit across the coronary ostia, and sort of, especially if you are somebody who is involved in doing a lot of primary PCIs, it's better to understand these valves. And the companies are working at putting at a fluoroscopy marker at the commissure levels in future, so that when we position these valves, because most of these valves are repositionable now, especially the Evolute, you can position in a fashion that it is not across the coronary ostia. Thank you.
Thank you, Dr. Entrapment. There are ways in which you can actually predict which are the ostia which would get occluded once you deploy the valve. Like it's aortic sinus is very roomy, we may not anticipate this complication. The ostium is very high, we may not anticipate this complication. But there are cases where you are clearly concerned and you put a wire and guide catheter outside the core valve. So what are those cases you would feel?
Now if you're going to use an intra-annular valve like Edwards valve, there's a difference. If you're going to use this core valve, which is a supra-annular valve, the valve opens at the supra-annular level, you need to know that. If you have a lot of calcium just below the coronary ostium, and the valves, when it opens, it will push the calcium towards the coronary ostium. So you need to know the distance of the sinus and the coronary ostia. It should be at least more than 10 millimeters. If it's not there, then you should protect it, as you said rightly. It is better to protect it either with a wire or a wire with guide catheter, or even with a wire guide catheter and a stent in place, either in the left main or right, before you deploy these valves. Now the other thing is the sinus diameters, especially for the core valve. The diameter should be adequate, like 25 to 27, 29, depending on the valve size. If it is not there, and if you are going to put an evolutor, then please do protect it with the wire and the catheter.
How frequently you are seeing these native atherosclerosis after these valves in TAVR, the real world? Have you have any incidence?
Yes.
The data is there.
Yeah. Now the quoted incidence is around 3%, but we are increasingly seeing this, especially in India. It is more of elderly patients who are having it, because not the younger patients. And those patients already have coronary or already have a tendency for progressive coronary artery disease. So we will see more often. But in West, obviously, they are moved towards more of lower, younger age patients and lower risk patients. There also we will start to see when they come for further valve-in-valve or further procedures. And that is the main issue with this.
Actually, let's say you take a 90-year-old for symptomatic aortic stenosis, and you incidentally find multivessel coronary disease. As a plan, you fix the coronary and then go for the tower. Is that correct?
Yes. So if it is a left main or the proximal LAD with large myocardial involvement, that is the only territory nowadays you need to be concerned about in terms of intervening, either as a procedure 2 to 3 weeks before, or some of them will do during the same setting. All the other coronaries, it can be left alone, and you can just go ahead and do the TAVI alone. The proximal vessel, proximal LAD, left main, large myocardial involvement, it's better to treat.
But it also depends on the age. Like say, if you're doing it for a 75-year-old, the fixing the coronary is going to be far more difficult later. So I think it depends on what you're handling. If you're handling a pure aortic stenosis subset, maybe the proximal left main or proximal LAD or left main area becomes important. But if you're going to be handling younger and younger subset, I guess these moderate lesion also will become quite important to handle later.
And it's easier to treat before you put these valves.
So much easier to treat.
If it is a simpler
before.
lesion, you better treat it rather than leaving it.
So there would be a clear bias towards fixing everything in the coronary before we go in, especially if you're handling a younger subset.
Is there any difference in self-expandable and balloon dilatable the valves for future crossing over and then?
Definitely, yeah. What we call it is intraannular or supraannular. This balloon expandable Edwards valve, all the other valves are sitting in the annulus level, intraannular level. So it is below the coronary ostium. So if that valve is placed, going for further intervention is much more easier. But if you had a supraannular valve like evolute, or then you have to go through the cell, the thromboid shell, through that first, through your catheter, and then into the coronary ostium. And that's where you have problems. At the moment, there is no markers to align these valves so that these cells or the commissures is not across the coronary ostium. So if one of those cells or this commissure is across the coronary ostium, that's where you have the difficulty. And that's where you have to use your non-selective shot, guide it over the wire, railroad, all those things. Very important not to go below the coronary ostium.
We had a proctor once in our initial cases, and we were doing a post-cabbage intervention. Right was sort of non-doable vessel, CTO long segment, and graft was not functioning. And he was very insistent that we have sort of viability study done for that area, which I think is driving a bit too far. I mean, there are areas which we have to leave behind, especially you cannot revascularize.
Yes. I think for us, everything is cost. Because when somebody is paying, because having worked in NHS for 20 years, coming back to India for the last 3 years, is a huge difference. There you don't think about cost. You can get what you want, alien scan, nuclear scan, other things. It will be Here the valve itself is 20 lakhs, and if you add the procedure cost, it's already 23 to 25 lakhs for a TAVI. If you order more and more tests, another 2-3 lakhs, the patient will not be happy. So we have to be sort of very thankful of that.
Any questions from the floor?
Thank you.
Thank you, Dr. Anantram.